Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinars. The speaker for today is our honorable guest from China, Dr. Alvin Nan. Dr. Nan is an associate professor in the Cerebrovascular Disease Center at Shanghai Hospital, Shanghai, China. He was previously a visiting scholar at the Houston Methodist Hospital, Houston, Texas, US, and his clinical interests are focused upon endovascular management of cerebrovascular diseases. He is also a noted author with several publications in various peer-reviewed journals, and we are extremely honored to have him today at our webinars. And today he'll be talking about flow diverters in aneurysms beyond the circle of Willis. The chair for today's webinar is our honored guest from Japan, Prof. Kenichi Haraguchi. Dr. Haraguchi is a senior assistant professor in the Department of Neurosurgery at the Fujita Health University Bantane Hospital. He previously worked at the Department of Neurosurgery at the Sapporo Teishinkai Hospital and the Nagoya University Hospital. His clinical interests are focused upon endovascular management of cerebrovascular diseases. We are extremely grateful and honored to have him today to chair the session of Dr. Alvin Nan. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speaker and chair to this online platform of ACNS webinar. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our Honorable Chair, Prof. Haraguchi.
Hi, nice to meet you, everyone. I'm Kenichi Haraguchi from Japan. I'm working with Dr. Kato since this April. So today we can listen a valuable lecture from Dr. Elvin Nan from China. And in Japan, we can now use a flow diverter since 9 years ago. However, we don't have enough experience about using the device, so I'm expecting the very good lecture from Dr. Elvin Nan. So please start the lecture.
Okay, thank you. So hello everyone. Today my topic will be flow diversion of distal intracranial aneurysms beyond the circle of Willis. I am Dr. Nan Lu from Shanghai Hospital, Shanghai, China. So in my today's presentation, the definition of distal intracranial aneurysms refers to aneurysms beyond the Willis circle, including ACA aneurysms, middle cerebral artery aneurysm, and PCA aneurysms. So these aneurysms have some common characteristics, like the distal route for endovascular treatment, the small size of the parent artery, mostly smaller than 2.5 millimeter, and it's mostly are bifurcating aneurysms and side branches involved. So, so as the development of the device and the imaging, endovascular treatment has become an important choice for intracranial aneurysms. And in some clinical trial or review, it showed that even more favorable clinical outcome better than clipping. So, but we still have some challenges of endovascular treatment for distal aneurysms because mostly the aneurysm was fusiform or dissecting and large, and if the branches involved, the situation will be more complicated. So sometimes we have to use some very complicated technique like Y-shaped stent or T-shaped stent to treat these bifurcation aneurysm. But as the emergence of the flow diverter, the treatment of internal cavity artery aneurysms was become very easy. We could deploy a single pipeline flow diverter inside the artery, and after 6 months, we could observe the totally occlusion of the aneurysm. But for distal aneurysm, it might not be so easy. So firstly, we applied flow diverter in some selected cases like some fusiform dissecting aneurysms. These aneurysms are not very easy to treat by conventional techniques of endovascular treatment. So like this case, a fusiform aneurysm of the M1 segment, we deployed a two-bridge flow diverter inside the artery, and after 18 months, this is the follow-up. The artery was reconstructed very well. So another case, this is the recanalized aneurysm. Um, Firstly, the aneurysm was treated by coil and a traditional Elvis stent here. But after 8 months, the aneurysm recurrence. So we deployed another pipeline flow diverter inside the previous stent. And after 10 months, the aneurysm was nearly totally complete occlusion. So this is another case of recanalized aneurysm, multiple aneurysms of the ACA, and we deployed a small flow diverter inside the aneurysm, inside the artery. And after 3 months, improved. And after 16 months, the aneurysm was totally occluded and the branches were patent. So these cases showed us that the feasibility of flow diverter in very small vessels, especially the improving design of the macrocaster and the flow diverter itself. So we could use the flow diverter in very, very small vessels to treat the distal aneurysm. Like this aneurysm, distal aneurysm of the ACA. If we use traditional technique, we have to deploy maybe 2 stents and to coil the aneurysm. But if we use the flow diverter, it's very feasible. We could deploy the flow diverter inside the ACA, and we could observe immediately stagnation of the blood flow inside the aneurysm sac. So we summarized our experience in my hospital from 2018. Totally 56 distal aneurysms treated by flow diverter, including 36 MCA aneurysm, 18 ACA aneurysm, and 2 PCA aneurysm. Mostly are fusiform or dissecting aneurysms. And the parent artery diameter was very small, mostly smaller than 2 millimeter. The technical success rate was 100%. And we obtained follow-up of 52 cases, a median follow-up period, 10 months. About 32 cases achieved complete occlusion, and 12 cases improved. The permanent morbidity and mortality was 3.8%. And we know that the occlusion rate will increase over time after the flow divert treatment, like showed by some previous studies after the immediate results. And after the first DSA and the twice DSA, we can see the occlusion rate increased over time. So, but we have to notice that there are some potential challenges for flow diverter in distal aneurysms. We could observe the 2 cases remained unchanged after the treatment, and the 2 occurred recanalization, and we still have some, ischemical and hemorrhagical complications. So we summarized these potential challenges to three points. The first one, aneurysm delayed occlusion. We know that the aneurysm involved bifurcation is an independent factor for delayed occlusion. Like in this case, MCA aneurysm, we deployed a flow diverter inside the artery. After 1 year, the aneurysm remained unchanged. So for these aneurysms involved branches and flow diverter, the result of flow diverter is controversial. This is not a case that occurred delayed occlusion. We treat the aneurysm, use the flow diverter. We could observe the several branches of the aneurysm. After 8 months, the aneurysm was unchanged, and after 20 months, we can see the aneurysm enlarged. So finally, we treat this aneurysm by clipping. So another challenge for the flow diverter treated distal aneurysms was the branches occlusion. Branch stenosis and occlusion is not rare in our experience and in previous publications. So the branches occlusion is related to the situation of the collateral compensation. In some cases of a good collateral compensation, the pressure gradient is reduced after the flow diverter treatment, and these branches are prone to occlude. In our experience, 4 cases occurred coronal branch stenosis during the follow-up, like this aneurysm located in MCA. After the treatment, in the follow-up, the stenosis of the origin of the branch. And mostly the chronic branch stenosis and occlusion is usually asymptomatic, but we should to avoid acute occlusion of these branches. Like in this MCA aneurysm, we treat the aneurysms use a single flow diverter, and the patient presented hemiparalysis 2 hours after the procedure, and after using the tirofiban, the symptom resolved totally. And another case, M1 segment dissecting aneurysm, we deployed a flow diverter in the M1 segment, and the LSA occurred acute occlusion. And we can see some acute infection of the on the MR examination. To avoid this occlusion of branches, we might to avoid not too much metal coverage inside the artery. The metal coverage of the flow diverter is higher than the traditional stents. If we push more, the metal coverage will increase, and sometimes we have to use multiple flow diverter to treat a large lesion. So in that case, the metal coverage will even higher than in a single flow diverter. So we should avoid to use too much metal coverage. Another challenge for flow diverter in distal aneurysm is the occlusion of parent artery. The incidence of parent artery stenosis or occlusion was reported to be 7% to 27%. mostly are asymptomatic. Occlusion is rare, but in our data, two cases of occlusion, one case of mild intimal hyperplasia, and one case of stenosis. And we can see in this case, M1 fusiform aneurysm. We deployed the flow diverter inside the artery, and 6 months after the treatment, a severe stenosis, we dilated the stenosis, and we followed to 2 months, still stenosis, and after 3 years, the M1 segment totally occluded. So we have to avoid the shorting or displacement of flow diverters to maintain the patency of the parent artery. In another case, an ACA aneurysm, we deployed an flow diverter here, from here to here. So maybe the distal segment of the stent is too short. So in the follow-up, after 6 months, we can see the flow diverter shortening and the ACA occluded. So to avoid the displacement of the flow diverter, we showed when we deployed the flow diverter, we have to locate it very precisely. So the stability of the deployment system is very important. The strong proximal guiding support, deliver the macrocaster as far as possible, and precise remote positioning, and withdraw the macrocaster to release the FD very slowly. So this is our experience to deploy the flow diverter. So according to our experience and the publications, the flow diverter is safe and effective in distal aneurysms, but we still notice that it's still lack of more evidence. We should improve our patient selection, improve our techniques, and improve our antiplatelet therapy to achieve the more satisfied results. And don't forget, we have more choices. We could claim the aneurysm to use the conventional endovascular treatment techniques, and we still have web or counter and other new devices. So the antiplatelet therapy is very important for flow diverter treatment. The routine, adequate, and long-term antiplatelet is very necessary for our treatment. This is the strategy of antiplatelet in our hospital. And the treatment will be even longer for the distal aneurysms if the aneurysm involved some important branches or perforator arteries. The antiplatelet will be even longer. So there's still a learning curve of flow diverter application in the in treatment of aneurysm, but we expect better clinical results of the flow diverter, and we have more new devices, the mini flow diverter. It make the treatment of distal aneurysm more easier. So this is my presentation. Thank you.
So thank you very much. Okay. So in Japan, now we can't use a flow diverter to for the peripheral regions. So the flow diverter is permitted to use only for proximal to M1 or A1. But we want to use to the distal aneurysm. So I have one or two questions. So after deploying the flow diverter, you said check the DSA every about 10 months, 1 or 2 times. And so when is the when do you decide to do the next treatment after that flow diverter deployment in the uncured case?
Okay. Thank you. So after the treatment of the flow diverter, we usually the first follow up will be 6 months here, 6 months. And after that, we could observe the senses of the parent artery or the aneurysm occluded. If the aneurysm is occluded at the first DSA, and after that, there's no need to DSA again. But for aneurysm that remain unchanged, we will adjust the antiplatelet strategy, and then we will, follow up for 6 months or to 1 year more. And after that, if the still unchanged, still remain stable, maybe we will suggest the patient to receive the maybe clipping or more endovascular treatment. Yeah.
So the deciding term is 1 or 2 years.
Yes. Because the occlusion rate will increase over time. So if the aneurysm is not enlarged, we could accept the result. It's stable. If the remain stable, I think it's acceptable result for flow diverter treatment. Yeah.
So you say there are adjust the antiplatelet. So do you mean that is a decreasement?
Yes, maybe. Yeah.
Okay. So another question is tirofiban. We can't use
Yeah.
Is that a 2A3B inhibitor?
Yes.
Okay. So, or is that the standard protocol when the thrombus was made during the operation?
Yes, we use tirofiban very conventional now. To sometimes to prevent the thrombosis event. Sometimes in the procedure, if you observe the thrombosis formation, we use the macrocaster to inject the tirofiban through the macrocaster in the artery. Yes, and also we will use the tirofiban through venous through intravenous tirofiban. Yeah, so tirofiban is very is used very commonly in our hospital now.
Is that for only single use? How about usage after the operation?
After that, we will use the through the wing. We will inject the tirofiban. Use a small dose of tirofiban through the venous approach, and we will tirofiban for maybe 1 or 2 days. After that, we change our antiplatelet strategy. Maybe change to ticagrelor. Ticagrelor is more effective than the Pavix. Yeah. So this is our strategy.
Okay, thank you. So we are waiting for the approval of that kind of drugs. So thank you very much. So how about the another comment or a question?
I'd just like to know from Prof. Elvin Anis, do you use for acute ruptured cases or also for unruptured aneurysms?
You mean in this series, they are all unruptured aneurysms, and for I think it's still controversial of the FD in ruptured aneurysms, but in some situations like the dissecting aneurysm of the vertebral artery and blood blister like aneurysm, the BVA aneurysm of the ICA. For these two situations, we will use the flow diverter in the acute treatment. Yeah.
So we have one question from the audience, who is Madonna Akobatse from Georgia, and she's asking, thank you for the wonderful presentation. Can you elaborate on the learning curve of FDs for distal aneurysms, and what advice would you give to young neurosurgeons?
Okay, so I think the learning curve of a new device will for every new device we will have a learning curve, and the flow diverter stent is the braid stent. It's not like a laser curve stent. Laser curve stent will be deployed very easily because the location will not, it will not shorten and the location is easy to, very easy to locate it in the perfect location. Yeah. But for braid stent, you have to push and pull to deploy the flow diverter, and we have to use some technique to achieve good position of the flow diverter. So I think the difficulty of deployment is here. So if for some new interventional physicians, I think we could start with laser card stent, and we could learn to deploy the braid stent after we have some experience of laser stent, and after that we could obtain some training outside the patient. In some animal or in some model of the vascular, and you have to try to several times to know how to deploy, how to push and pull the stent to achieve good position. So this is maybe my suggestion for new physicians. Yeah.
Thank you very much. That was very valuable. I think if there are no more questions, we can wind this up. Haraguchi.
Yes, thank you very much.
I think we can wind this up officially now. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank the speaker, Dr. Elvin An, for his wonderful lecture, and also Dr. Haraguchi Sensei for sharing our session. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as of now, we have around 320 people who have joined us live from across the world. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.